For starters, the primary goal is going to be to set up some reasonable expectations for our patients. So, first of all, we have a population of people that is large, approximately 1 billion people in the world with migraine. And the thought is that there's about 40% of them that are actually candidates for some type of preventative therapy. And a significant proportion of that 40% doesn't actually receive the kind of preventative therapy that they need. And so what that equates to is a very large burden that is exerted upon the population that can't function normally because they have headache of a very high frequency. So we need to not only identify those people and recognize who is a candidate for therapy, but then also make sure that they're receiving the right kind of therapy. One of the things that we look to do is set up some reasonable goals. So especially when you have an individual who has headache on most days or every day, it's going to probably be a process. And it is going to be a very rare event that you start or initiate some type of therapy and immediately they just feel fabulously better. So what we need to do is break these expectations down into some reasonable goals, whether it's decreasing their daily severity of pain, or whether it's to decrease the severity of their acute attacks, or perhaps even to make them more responsive to acute therapy. These are all things that can actually be markers for success and that you're actually on the right track with them. Well, I think if you ask a patient what they want, I think without a doubt the overwhelming response is going to be that they want to be pain-free. And in reality, we know that that is just not possible in certain populations of people. And there's a lot of neurobiochemical reasons why that may occur. There's certainly a lot of changes that occur that make someone a little bit more prone to having pain for an indefinite period of time. And those are the people where you really do need to focus on functionality, as you mentioned, where maybe the goal is not going to be pain freedom, but to be able to learn how to function and how to cope with the pain that they experience on a daily basis. At the moment, there's a pretty large body of evidence-based treatments that we use for migraine prevention. And the interesting thing about that is that that list is actually several years old. And it doesn't reflect some of the newer agents that are coming out, or even some new, more contemporary studies on agents that didn't make those previous guidelines. So, no doubt, especially now that CGRP medications and monoclonal antibody therapies are coming out, there will be a very large new armamentarium that we will have available to treating headache patients. And it seems like the early studies on those medications are very promising, that not only are they efficacious, but they're also very well tolerated. And it seems like they're going to be appropriate medications for populations of people that perhaps some other medications that we use frequently are just not appropriate for. The issue, of course, is going to be cost. And what is that going to mean to the accessibility of these medications? In addition to medications, though, we have a number of other things that are coming out, and those include devices and things that are gaining not only a lot more popularity, but are also really showing through various studies that they're effective. And that includes things like single pulse transcranial magnetic stimulation, non-invasive vagal nerve stimulation, and even peripheral stimulation through devices that stimulate supraorbital nerves, or even implanted devices that can stimulate greater occipital nerves. Frequently, we see patients that have a number of other comorbid conditions. And we also see people present with issues that can also be a direct result of having chronic pain. And so when we identify those people and we can identify those other problems, whether it be cardiovascular risk factors or cerebrovascular risk factors, depression, anxiety, GI issues, we look to try and pick medications that may not only work for treating their headaches and their chronic migraine issue, but also may treat some of their other comorbid conditions. So we can frequently try and titrate anti-epileptic medications, antidepressant medications, antihypertensives to get more than one treatment effect out of them. I think if there was anything I had to tell patients about preventative therapy, it would be that if they experience headache on a frequency more than one time a week, or if they find that their acute medications are just not working, or if they have conditions that are very unique, where perhaps half their body becomes weak with their migraines, or they experience some of these rare migraine phenomena, or even if they just experience a high degree of disability from their attacks, that they might be candidates for preventative therapy, and that it's important to talk to the person treating their headache and discuss whether or not they should be on preventative therapy, what preventative therapy should be for them, and what sort of goals and expectations that they should have for their treatment.